Hello, everyone, and welcome to today's menMD RealTalk webinar, Injection Therapy Online Clinic. My name is Austin Hunt, and I'll be your moderator for this event. I work on the marketing team here at menMD, and I'm excited to be hosting the session today. Before we get started, we have a short disclaimer that we need to review.
The health and medical information provided during this webinar, as well as the questions and responses from the webinar providers, are solely for informational purposes. This content is not intended to take the place of advice or treatment from health professionals. Nothing presented in the webinar is intended to be used for medical evaluation, diagnosis, or treatment. It is not intended to substitute for your relationships with your own healthcare and pharmaceutical providers. Always seek the advice of your healthcare provider before beginning any new treatment, or if you have questions regarding a medical condition.
All right, with that being noted, I'm pleased to introduce today's presenter, Patrick Carpenter. Patrick is a pharmacist located in Portland, Oregon, who specializes in erectile dysfunction, drug regulations, and pharmacy compounding. Today he's going to cover injection medication, syringe and dosing, injection techniques, support options, and then hold a live Q&A to close out the webinar. So without any further ado, I'd like to kick things off by welcoming our presenter. Patrick, over to you.
Great, thanks, Austin. Welcome, everyone. Before we get started with the presentation, we have some poll questions. There's 3, so let's go ahead and launch the poll questions, please. How long have you been experiencing erectile dysfunction? Select one of the answers, please. About half are 3+ years, with the next largest being 1 to 2 years, 6 to 11 months, and a few people just starting. All right, thank you for that information. Have you ever performed an injection on yourself and not received the desired result? Have you ever done an injection and not gotten an erection? Yes or no? 3/4 of people, 76%, have done an injection without getting the desired result. 25% of people have always gotten the result they're looking for. Very good. And finally, have you attended one of our previous menMD RealTalk webinars? Yes or no? Have you attended a webinar from menMD before? 40% yes, 60% no. More new people this time than repeat customers. All right, well, welcome. Thanks for coming again to those who have been here before, and welcome if you're new. What we're going to do here is go through some slides. There's maybe 20 slides here. Probably have that take 15 minutes or so. And then I'm going to do, I've got some props here. I have vials and needles and a penis that we're going to actually inject, a rubber penis, a bunch of different accessories. I've got a VED, so we can do some demonstrations on injection technique. That'll take maybe 5 minutes. And then we'll open it up to questions, and looking forward to interacting and answering questions. So we'll begin with a quick overview of the erection process. Normal physiology is first there's mental arousal. You begin with sexy thoughts, and that causes change to innervation to the penis, which causes smooth muscle relaxation. That smooth muscle that surrounds the arteries that supply blood to the penis relax. The arteries send more blood into the penis. That blood is what causes the fancy word is tumescence. That's what causes the erection. And then as the erection fills with blood and hardens, that squeezes the veins that allow blood to leave the penis. The normal process of an erection is a delicate balance of blood flow into the penis from the arteries and out of the penis from the veins. And again, it all begins with mental arousal typically. Let's talk about what we call ICI, or intracavernosal injection therapy. We'll talk a bit about the medication, the syringe, and some real high-level dosing strategies. How do ED medications work? Well, they increase blood flow to the penis to achieve and maintain an erection strong enough for sexual intercourse. In the case of ICI, it's a combination of 1 or 2 or 3 smooth muscle relaxants that are injected into the penis, again, to allow increased arterial blood flow. The most commonly used medications are alprostadil, papaverine, and phentolamine. Trimix is a mixture of all 3 of those. Bimix is most commonly a mixture of papaverine and phentolamine. Of note, that first chemical, alprostadil, that is also known as prostaglandin E1 or PGE1, or sometimes people will just refer to it as prostaglandin. Throughout the presentation, I will call them alprostadil, papaverine, and phentolamine. What you're seeing here is a list of menMD's formulations, starting at the top with Bimix, going from weakest to strongest. So Bimix 3, 4, 302, and then Bimix 10 is the strongest. And then unrelated to that are standard trimixes and low alprostadil trimixes. You see standard trimix starting at trimix 5, going all the way up to the strongest trimix 16. And then separate from that are these low alprostadil trimix formulations. The reason they exist is that about 1 in 5 men who inject a product that contains alprostadil will experience an aching sensation in the penis. And although the aching sensation is harmless, it can be annoying. And in some men, it's so severe that they have a hard time moving around, or it's impossible to touch the penis or have penetrative intercourse because of the aching sensation is so strong. So what we do there is it's a dose-dependent reaction. So if you need the alprostadil in order to get the erection that you're looking for, we can try and decrease the amount of alprostadil that's in the formulation to still harness some of the effects from it, but stay below the amount that's going to cause that aching sensation. Needle size and dose volume. You see a picture of the needle and syringe over there. These ICI medications are injected into the penis using a very small needle. It's also referred to as an insulin needle or an insulin syringe. Technically, the syringe is the plastic part that has the gradations on it, and the needle is the shiny silver tip, but it's not uncommon to call the whole thing a needle or a syringe or whatnot. Your physician is going to make a recommendation about the needle and syringe that you're going to use. In many states, the needle and syringe, these insulin type syringes, are sold over the counter, but you want to pay careful attention to the gauge and length of the needle. Again, talking about the shiny silver tip, the actual needle. There's a 5/16 of an inch needle that you can use. There's a 1/2 inch needle that you can use, and your injection technique is going to change a bit based on the length of that needle. So it's not necessarily completely interchangeable. Maybe your physician taught you how to inject using a 1/2 inch needle, but then you subsequently learn that there's a shorter needle and everyone wants the smallest needle possible to put into their penis. So you might switch. And then if your results change, well, it's because your technique needs to change a little bit based on the length of the needle that you're using. So just pay attention to the length of the needle, the gauge of the needle, and again, we can talk more about that when we get to the demonstration. Of note also, because these are insulin syringes, it's very common for the gradations on the syringe to be labeled in units. In that picture on the screen, you can see sort of very clearly 60, 70, 80, 90, 100. That's insulin units. Your dose may also be given in milliliters or mLs. You see on the screen 0.3 mLs. That's the same as a cubic centimeter. So if someone refers to your dose as 0.3 mLs, that's the same as saying 0.3 cc's, which is the same as saying 30 units. Again, 1 ml, 1 cc, 100 units. In the case of that picture, that would be a full syringe. We can change to stronger mixes so that you can inject a smaller volume. The amount of liquid that you're putting in that syringe we'll refer to as the volume. That's a measure of liquid. If you are injecting more than, say, 50 units or 0.5 cc's, 0.5 mLs, it may be possible to move you to a more concentrated solution so that the volume of your injection can decrease while achieving the same results. So starting dose, adjusting your dose, and logging progress. I'm a big proponent of logging your progress. This is not as simple as something like taking an oral medication and then seeing what happens. You're going to potentially change your concentration, and you're going to change your volume of injection, and you've got to pay attention to your injection technique. So I tell patients to expect to have to practice about 6 times before becoming an expert at this and before having your results really dialed in. And if you're doing this, typical recommendation is not to inject more than 3 or 4 times a week. So if you're injecting 3 times a week, and I'm saying you're just starting and it's going to take 6 times before you get this figured out, you don't want to be at the end of a 2-week period, 14 calendar days, thinking about, geez, what happened on injection 1? So keep a little log, and I believe menMD gives you some paperwork where you can keep track of the date, the volume injected, the duration of the erection, and the rigidity. Big fan of using that 0 to 10 rigidity scale. You see where 0 is no change in blood flow to the penis. 10 is a maximal rigidity, rock hard erection like you probably had when you were younger. And then 6 we say is just sufficient for penetrative sex. And that's a real handy way for you to communicate to your case manager or physician when you're talking about your results. So keep track of those results on that rigidity scale as you're logging your progress. And that's going to make it really easy to get you dialed into the right concentration, the right dose, so that ultimately you can stop thinking about that and just come to expect that your injection is going to work every time. What's our goal? Well, our goal is a full erection that mimics your normal physiology. So we want it to come down in a reasonable period of time. So ideally, you're going to inject. Shortly after the injection, you'll get an erection that's sufficient for intercourse. You'll have intercourse, masturbate, whatever it is you're doing, have an orgasm. And then shortly after the orgasm, again, just like normal physiology, you'd lose the erection. That's our goal with ICI therapy. A partial erection that's not rigid enough for the duration of intercourse means that the dose may be too low. There could be some other physiological factors that are at play there. And the typical answer, assuming your doctor's order allows that, is to increase the volume of injection so that you get a stronger erection or a longer duration of erection. Couple of notes. Don't exceed your maximum prescribed dose. You know, as when I talk here about raising the dose, that assumes that your doctor's order is written to allow that. Don't inject more than once in a 24-hour period unless otherwise directed by your physician. You know, this comes up sometimes. Guys will say, well, I injected the first time and it didn't work perfectly. What do I do? Or sometimes they'll say, well, it's my anniversary and we want to have sex at night and then again in the morning. And, you know, as a general rule, you want to inject no more than once every 24 hours. And as I mentioned, no more than 3 to 4 times a week is the typical physician's order. Preparing for your injection. Again, I'll go quick through this because I'm going to actually show you a demonstration in a minute. You're going to gather your supplies, prepare the medication, and then perform the injection. So you've got your vial of medication. That may come in an amber vial from the pharmacy also. There'll be a couple different labels on there. You've got your syringe and needle, as we discussed. You've got your alcohol prep pads. Those alcohol prep pads are going to be used to clean the top of the medication vial, but also the side of your penis. You're going to remove the orange cap from the syringe. That's going to expose the needle. Pull the plunger back a bit to the desired dose. That pulls some air into the syringe. You would then pierce the rubber stopper on the vial with the needle, push the air into the vial, pull back on the plunger to fill the syringe with liquid. You want to look to make sure there's no gaps of air. You know, sometimes people get really worried about this and say, well, what if I inject a little bit of air? You're not going to hurt yourself if you see a small air bubble in there. What we're concerned about is, although you don't want to inject a bunch of air, what we're concerned about is that the air bubbles are going to interfere with the measurement of the liquid and your dose is not going to be right. So next, swab the injection site with the alcohol pad and allow it to dry. You want to allow it to dry to give the alcohol time to kill any pathogens on the skin. And also, if you were to pierce through the wet alcohol, that's going to cause some additional burning. Insert the needle into the shaft of the penis between the base and midpoint. There's a couple different spaces that you can inject. I'm a big fan of going right in the side, right at 3 o'clock or 9 o'clock, just like you were going in the side, like the wing on an airplane. But you can inject anywhere, as it says here, from 9 to 11 or from 1 to 3. You want to avoid any veins, again, not because you're really going to hurt yourself, but because there's going to be more bleeding, higher likelihood of bruising if you go through a vein, more bruising, more bleeding. So you try to avoid veins. You're going to gently depress the plunger to inject the medication. As a general rule, I say for every 10 units of fluid that you're injecting into the penis, it should take 1 to 2 seconds to perform the injection. So if you're injecting 10 units, you're going to count 1 1,000, 2 1,000 as you're injecting. If you're injecting 50 units, half of 0.5 cc's or half of a 100-unit syringe, that injection should take 5 to 10 seconds. So that's another reason to try to work with your case manager, your physician, to lower your volume, because you're quicker in and out of the side of the penis with the needle. Remove the needle and then apply compression to the entry site for 2 to 3 minutes. Again, that's going to just prevent any bruising or minimize the likelihood of any bruising or bleeding that can occur from the needle puncture. Side effect mitigation with ICI, you want to use a proper injection technique. Ideally, your first dose is going to be taught in your doctor's office. They're going to, again, orient you hands-on with the needle and syringe. That's also going to allow the physician to see your dose response and get an idea of what strength medication to send you home with and what dose to start you on at home on your own, so that that's done safe. See a urologist experienced in setting the initial medication strength or dose. You want to rotate your injection sites. So I talked about the ideal space. When I'm teaching, I like to recommend 3 o'clock or 9 o'clock. You do need to vary your injection sites to avoid buildup of scar tissue in the penis. You can do that by slightly varying the where on the length of the penis you're injecting, but also varying the where in terms of circumference you're injecting. And then, as I mentioned, no more than once every 24 hours or as directed by your physician. You want to store punctured or sealed vials must be stored refrigerated. This is a compounded medication. It's best stored refrigerated. And the beyond use date, that's in pharmacy compounding, the term beyond use date is like an expiration date. I won't get into the regulatory differences about why we use one or the other, but the beyond use date on any compounded medication like this, really by regulation, needs to be 28 days after the first puncture or the underlying expiration date on the vial, whichever is sooner. The reason for 28 days after first puncture is because these environments are compounded in a very specialized environment. It's not just made in ambient air like that's surrounding us now. And then when you puncture into that vial in the ambient air, like at your bedside table or wherever you're going to be doing the injection, you run the risk of contaminating the vial, getting particulates in the vial, even filling the syringe up with air. You are injecting air into the vial. If you think about maybe seeing the sun come through a window and you can see dust floating in your environment, the air around us is dirty. Sometimes people don't get that. They think, well, geez, I live in this air. How come I'm safe? Well, that's because your lungs and skin are designed to protect you from that. But with this, you're bypassing your skin and you're injecting right into your bloodstream. So there is some heightened sort of concern around the beyond use state. We don't want to use a vial forever. Injection accessories. There's, again, injection tools. We'll talk about safe syringe disposal, and we'll talk about a travel case. You see some of that here, the Insel tote. This has a nice chip in it, a gel pack that you can freeze to make it a little easier to travel. You can see the Insules. That's really a magnifying glass. So if you have trouble with your eyesight reading the dose on the syringe, that will magnify it. I've had some patients too with other conditions, maybe Parkinson's disease, and they're a little shaky or just general dexterity issues, and that Insules can make it a little easier to hold onto the syringe because it makes the whole thing bigger. Same with the auto injector. The auto injector really hides the needle from you, so you push a button on there and it is spring loaded and it pushes the needle into the penis. There are pros and cons of this. Personally, I would prefer holding on to the needle and syringe to be really accurate. Adding the auto injector, although it can help you overcome fear of insertion of the needle, you lose a little bit of fine tuning and assurance when you're learning how to do the injection. And then, of course, a sharps container. That's where you want to put your disposed needles and syringes. So you can throw other things in there and just make sure you're not throwing this stuff in the trash. All right, if you need help for more information, you can contact a menMD clinical case manager. They're going to provide answers and insights to your question about treatment effectiveness. Again, it's very common for men to call in and say, well, I injected 3 times. This was my dose. This was the result I got. What do I do next based on my doctor's order? They can help communicate with your physician to change strengths. Wealth of information there. Big fan of the clinical support that menMD offers. Used to do it myself. There's some information about how to reach menMD. With that, this says question and answer, but I want to do a demonstration first. So I'm going to close the screen down here.
Good to go.
All right, thanks so much. Okay, folks, so we'll do a demonstration. So I have a vial here. You see the amber vial from the pharmacy. There's no label on this. I will open that up and then take out the vial. Again, this is an unlabeled vial. I just have water in here, but this is what your vial is going to look like. It may have more fluid in it. You see the rubber stopper up top, that's where we're gonna puncture. Trying to adjust my screen. You see there's actually a circle in there. You're gonna try and get the needle right through there. I'll show you a couple different needles and syringes. This is just happens to be a Short Comfort brand. You see here the volume, that's 1 cc or 100 units, 1 ml. This is talking about the needle length, 1/2 inch needle length right there. And then this is the gauge, that's the thickness of the needle, sort of how big around in terms of circumference, 29 gauge. I'm going to work with my preferred syringe, and again, there's no, you can do an injection with a variety of different syringes. I'm just most used to working with a 1 cc, 5/16 of an inch, 31 gauge. So I'll take one of those out. Again, we talked about the syringe, the cap. There's a cap over the plunger. Here's your plunger. And then if I remove the orange cap, you'll see the needle tip. Try to get close to my camera. You see very, very tiny needle there, both in terms of length and gauge. I've opened that a little prematurely, so I'm going to close that again. All right, so step 1, take the alcohol pad, open that up. I'll try and do as much of this on screen as possible. My tendency is to lower my arms. Okay, you want to wipe your vial top here. Again, just make sure that there's no pathogens on top of that vial. We'll let the alcohol dry for a minute. You would then wipe the side of the penis. I've got a small flaccid penis prop here. I'm going to inject as if we're going into the left side. You want to sort of swab around the side here very generally to clean more of the area than needed. This is a little more natural when it's your own penis because it's attached to your body, so you need one less hand here. We're going to wait a few seconds. As I said, the slides recommend 30 seconds to wait for the alcohol to dry. I'm going to sit the penis down again while I'm going to draw up the medication. I'm going to just say our dose is 30 units. So I draw back. Takes sometimes you got to just move the plunger a little bit to get it going. I'm going to pull back here to 30 units to fill with air. Try and show you that as best I can. You see the 10, the 20, and I'm right on the 30. You're measuring from the top part of the plunger. All right, I've got my vial. Again, we wiped that with alcohol. I'm going to go straight in with the needle. Again, it's a little awkward for me to try to make sure I'm doing this correctly and see it, but also showing you I'm entering right into the vial there. Because of the small amount of liquid in the vial, you've got to invert all of this. I'm going to push the air that I drew up in. Maybe you can see bubbles going into the liquid. There's not enough pressure in there to push the plunger back, but I'm drawing up. I've got a little air bubble there, paying attention as I go, maybe smacking this to try to get the air to go to the top. I can pull the plunger back so quickly here that there's still a gap in the syringe. So you want to really make sure to watch closely to make sure that it's filling. What I've done here is overfill a bit. I don't see any air bubbles. I'm smacking the side here to loosen any air bubbles. And now I'm watching very closely here as I push to the gradation for 30. And there it is. I've got 30 units in my syringe. I'm going to disconnect from the vial, put the vial down. Now, as we talked about in terms of, I'm showing you this awkward angle here with the penis, but in terms of length, I like to tell patients to go halfway between the tip of the penis and the body. So we're going to inject right about here. You can inject a bit closer to the base also. When I talked about sort of moving around to rotate injection sites to minimize scar tissue formation, you can certainly move closer to the body. You want to avoid injecting near the head or the tip of the penis, not necessarily because you're going to hurt yourself in terms of damage, but because that's the more sensitive area of the penis. And so it's just going to hurt more. And the erectile tissue sort of changes a bit up there. So it's going to be harder to get the desired result. So in terms of the length of the penis, you're going to inject about halfway between the base and the tip. Again, I'm going to be targeting right there. And then we talked about in terms of circumference, where do we go? Well, anywhere from 1 o'clock to 3 o'clock, or on the other side or this side, that would be 9 o'clock, 9 to 11. I'm a big fan of going right straight in the side. So you want to go in sort of swiftly. You've got some thicker tissue underneath the skin that you've got to puncture. Right straight in with one push. And with this shorter 5/16 of an inch needle, you don't have to worry about going too deep. You want to depress so that there's actually a little indent right in the side of the penis. So, not too deep, but with the 5/16 of an inch, it's easy to not go deep enough. So don't be afraid to push so that there's a small indent right there where that shiny silver needle meets the plastic of the syringe. That's called the hub. And so you want to push so that the hub makes a small indent. And I'm just moving this around now. Again, you wouldn't be doing this much manipulation, but I'm just moving it around all angles here so you can try to see what's happening. So you've got the head of the penis lifted up, you've pressed the plunger in, you wouldn't leave it lingering this long. Again, I'm just talking through the example here. And then you're slowly depressing. Remember, I put in 30 units, so I'm thinking 3 to 6 seconds. 1, 1,000, 2, 1,000, 3, 1,000, 4, 1,000, 5, 1,000, the injection's in. When I was depressing the plunger, you might have seen the penis bows a little bit. That's fine too, to be pressing to make sure you've got to get the medication to that target area. You remove the needle. I'll put that in the sharps container in a minute. And then again, you'd put some pressure here on the penis. So you're squeezing, almost like you're squeezing a straw, as if you were trying to stop the flow of liquid through a straw. You're putting pressure there at the injection site to minimize bruising and bleeding. You could even sort of massage a little bit here. If you can see, I'm moving my fingers to help move the medication around and begin to stimulate the penis. Okay. Sometimes, you can bend the needle when you're practicing. If you're entering the vial or even entering the penis, sometimes guys will go too slow out of nerves, and the needle bends. When the needle bends, my recommendation usually is to not fiddle with it anymore, to throw it away and start again. And this happens more commonly with the 1/2 inch needle. You can bend the needle when you're going in. And then sometimes guys will try to straighten it. But again, in terms of precision, you've got to get right into a very certain spot in the penis. That target area is very important. And so if the needle's bent and it's coming off the syringe crooked and then you try to inject, you're just setting yourself up for a disappointing experience. So if the needle bends when you're going into the vial or when you start to inject, I would just abandon and start over again with a needle that's not bent. In terms of onset of action, the erection should begin to develop in 5 or I would say no more than 10 minutes. Again, it helps to interact with the penis, stimulate the penis, have your mind in the right place, and keep track of your dose. From there, it's about fine tuning and about getting comfortable with the process. And most men who use injections are able to get an erection sufficient for sexual intercourse. And again, I've treated thousands, if not tens of thousands of patients and help patients become successful with injections. So with that, I'm going to turn it over to Austin for questions and answers, and looking forward to talking more.
All right. And to your point about logging and tracking your success, the handout that I mentioned at the beginning of the webinar has one of those trackers on it. So if you guys download that, you can keep track there and use that as a tool. And then they also come in, yes, that's exactly it right there.
Right here, yeah. So there's a
helpful printed out version that comes
and a picture, and this will come with your shipment. And again, the rigidity scale is there and the tracking guide.
Yep, yeah, it comes with your shipment. You can also download it here. So handy dandy tool right there. But yeah, let's get into the questions now. First question comes from somebody, seems like they might be a little bit newer. I've been using pills, but now every time I take a pill, it doesn't last and my erection goes down really quickly. Does that mean I need to look into stronger options like injection therapy, or are there other options?
Well, general questions like this can be a challenge because some of this could be your underlying, sort of the underlying condition that's causing your erectile dysfunction. So people will sometimes say, am I developing a tolerance either to the oral medication or to the injection? And there's typically not a tolerance. I would say that what's happening is you're getting older, or maybe you have diabetes, and it's been another year of aging and another year with diabetes. And so the underlying factors that are causing the erectile dysfunction are likely worsening. And it's just the ravages of time, and people will perceive that as tolerance to the medication, but it's really more of just a worsening of the underlying conditions. There's dosage range on oral medications. So sildenafil, for example, 20, 25, 50, all the way up to 100 milligrams of sildenafil. Same with tadalafil and the other medications. So there's a possibility of talking to your doctor about raising your dose to make sure that's safe for you. You would, again, just with oral medications, just like injections, monitor the rigidity and the duration. There could be other reasons why your response has changed. There are some over-the-counter medications like Sudafed that make it harder to get an erection. So if you happen to have a cold and you're taking Sudafed and then you take your oral medication or do your injection, you might get a blunted response to a dose of medication that would otherwise work for you. So the progression typically, and again, it depends on the underlying reasons for erectile dysfunction. If you had prostate surgery, it's possible that right after prostate surgery things are worse, but over 6 to 12 to 18 months, some nerve function will return and things will get better. So to answer your question, I'd love to know more about you, which this format doesn't allow, but increasing your dose of oral medication, or certainly trying a VED or trying injection therapy would be the next steps.
So on to the next question here. Can you combine using injection therapy with tadalafil or sildenafil?
You can. I think the question is why. A general rule of pharmacotherapy when you're treating a condition is you want to try, because there's risks associated with any drug, right? You want to minimize the number of things that you're exposing someone to. You want to use the lowest effective dose in any treatment. Same as if we were treating blood pressure, for example. You don't begin treating high blood pressure by giving someone 5 drugs. You'd start with one, maybe a diuretic, and again, it's besides the point. But so it's not unsafe necessarily to combine tadalafil or sildenafil, an oral medication, with injection therapy. But the question is why. So typically, because oral agents are easy, just by virtue of the fact that they're oral, that's where patients begin. If your oral therapy is not giving you an erection sufficient for intercourse or of sufficient duration for intercourse, you would typically then move to ICI, move to injection therapy. And I would say in that case, the answer isn't to continue taking the oral medication and add on injection therapy. You would abandon oral medication for a time and try injection therapy alone to see if that's working. Now, there are reasons why that may not be the case. Again, post-prostatectomy, there's value in taking sildenafil or tadalafil every day in terms of minimizing scar tissue and helping nerve function come back. And in a case like that, you may be taking tadalafil or sildenafil daily, but still injecting. Again, just sort of putting some of those more complicated clinical situations aside, just focusing on getting and maintaining an erection, would say you try oral agents. If they don't work, you stop oral agents, then you go to injection therapy. You would titrate up through various doses of injection therapy, bimix, trimix, going back, thinking of the scale of menMD products, trimix 5, trimix 8, trimix 9, trimix 13, trimix 16. And so you would go up in strength there, again, increasing the volume of your injection based on your doctor's order, based on working with menMD, working with your physician. And then if you got all the way up to trimix 16, for example, and that wasn't working, that's when I would begin to think about adding on oral agents on top of injection therapy. Or if you think of that other graph that we showed, or picture that we showed, of low alprostadil trimixes, those guys who, where I said 1 in 5 will have an aching sensation from injecting alprostadil, maybe you're using a low alprostadil trimix and then not getting the results again after working up through whatever those mixed numbers are, trimix 6, trimix 7, it's really testing my memory now, 11, 12. That's a case where you would then think about adding on sildenafil or tadalafil or another oral agent. Hope that helps.
All right. I'm right-handed. I can't master a left side injection. Is it practice, 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 or is there a trick to this?
You could try reaching over. So you're still, if you're right-handed and you're holding the syringe in your right hand and you're holding your penis with the left hand and you're used to injecting in the right side, I'm wondering if there's an ability to reach over and inject rather than holding it in your left hand. I would say practice. Depending on how frequently you're injecting. I mean, remember that the rule is 3 or 4 times. The general rule is no more than 3 or 4 times a week, no more than once every 24 hours. If you're injecting once every 2 weeks only, again, I'm just making up numbers here, but let's say you're injecting once every 2 weeks, I'm less concerned about you repeatedly using the right side, assuming that you are varying in terms of the length and maybe varying in terms of the circumference where you're going in. In that case, I'm less concerned about you necessarily switching over to the left side. It's always best. Why not use all of the real estate possible? But again, if you're not maxing out, it may not be as essential to switch over to the other side. But my quick advice is maybe try reaching over rather than switching hands. Hope that helps in some way.
All right, I got a question here about bent needles. I've been injecting for over 20 years, and now I have trouble getting the needles into my penis because they bend. What can I do?
So what's interesting about that question, the setup, is that you said you're a very experienced injector. You've been injecting for 20 years, but now they bend, right? So the takeaway I get from that is that almost as if for like 20 years, everything was fine, and now the bending has started and you don't know what to do about it. That could be a sign that there's been scar tissue development in the penis. You're going through very soft skin, and then you hit a tougher layer of tissue called the tunica albuginea. Sometimes when guys go in too slowly and they go through the soft skin and then they get to the tunica, that'll feel like a little resistance and that will cause the needle to bend. You want to push right through that. In your case, again, an experienced injector, I'm assuming you're not talking about just hitting a more fibrous layer of tissue. It sounds like maybe there's been some scar tissue that's developed. So you would want to rotate injection sites. Try the other side of the penis, try varying the length, try varying the angle that you're going in from the perspective of circumference. You could talk to your doctor about a longer needle. If you've been using a 5/16 of an inch needle, it would be possible if there is a little bit of scar tissue to push right through it and get in a little deeper. Yeah, it's really about, again, assuming without it, having done an exam or talking more specifically to you, the setup of that question, the fact that sort of like all of a sudden after all these years, the needles are bending, it sounds to me like there's some thickening of the tissue that's developing, and the answer would be to try to avoid those spots. Feel the penis, squeeze it, see if you can feel anything in there. And maybe you'll recognize a feeling of a little bit of lumpiness or something thicker in the area where you were prone to inject for all of these years. Maybe move closer to your body. If you have been doing more like an inch away from the body or the midpoint of the penis, you can come right close to the body. Maybe you'll avoid some scar tissue that way. That's the advice that I have for you about overcoming that.
All right, got an interesting one here for you. I had an ER visit from Trimix. I'm now on Bimix number 4 and use 15 milliliters with a 4-hour erection at 75%. I'm trying to get to 100%. Will a larger dose increase the duration or hardness, or am I risking another trip to the ER?
Got it. Barry, can you read that one again for me, Austin, please? I want to write down some of the numbers.
Sure. I'll start where he talks about the Bimix that he's using. So he's on Bimix number 4, uses 15 milliliters. He gets a 4-hour erection at 75%. So he's trying to get to a full erection, 100%.
Okay, Bimix number 4, it says 15 mLs. I think that means 15 units, 0.15 mLs, just to be really precise about the dose. 15 mLs would be 3 teaspoons. So I just want to be, it would be impossible to inject that. And I'm not criticizing you by any means, but part of the purpose here is to be really precise about our language and the pharmacist and me. It's part of my professional responsibility. So I'm going to assume we're talking about 0.15 mLs or 15 units. Just to hammer that point home, where this is a 100-unit syringe, 15 units would be halfway between the 10 and the 20. So small amount in this syringe, 15 units. the gentleman says he's getting a 7 out of 10. Love the use of the rigidity scale. So 0 to 10, 0's no change in rigidity, 10's maximal rock hard erection, 6 would be just sufficient for penetration. This is a very common question, sort of like, I'm getting an erection that's good enough for penetration, but you know, I want an 8 or a 9 or a 10. It's lasting for a long time, right? So what do we do if we're trying to avoid erection that lasts longer than 4 hours, because we start to get into priapism territory, and erection that lasts longer than 4 hours can actually damage the smooth muscle in the penis, can make it so that injection therapy and oral medication doesn't work anymore. So you definitely want to try to avoid a duration of longer than 4 hours. And so this gentleman's dilemma is he's getting an erection that lasts 4 hours, but he's not getting the rigidity that he wants. How do we solve that? So, and he's talked about a trip to the emergency room, which, you know, if you go to the emergency room on time, they're injecting phenylephrine, you know, but that sort of ruins your night. You didn't have the sexual experience. You're waiting in the emergency room. So how do you manage all of this? Well, I would say our goal is really an 8 or a 9, right? So trying to push to a 10, you know, a little bit of this is realigning your expectations, and maybe let's not have a 10 out of 10 be the goal, but I think you're reasonable to want more than a 7, and it's reasonable to try to push to an 8 or 9. Couple different things. So in terms of the type of erection that you're having to 4 hours. So what we worry about a patient having for 4 hours, I don't want to get too technical here, but there's ischemic priapism and non-ischemic priapism. Not every 4-hour erection is problematic. The trouble is there's no way to know. You have to go to the emergency room with this prolonged erection. They draw blood gases out of the penis and they look at how much oxygen is in the penis. That's how they determine whether this is a safe or an unsafe priapism. But if you are at the 4-hour mark and you have less than a 5 on that scale of 0 to 10, I'm not really worried about that. So I'm worried about an erection that's sufficient for penetration for longer than 4 hours, because that's an indication that you're not getting fresh arterial blood flow necessarily. So if this erection that you're describing lasting for 4 hours is bendable, if it's a chubby, you know, to use the vernacular, if this is a 3 out of 10, you know, I'm not necessarily concerned about that. So in that case, you know, and that's a common occurrence. You do an injection, you get an erection that's maybe a 7 out of 10, you have sex, you have an orgasm, and then you know, maybe that goes on for 30 minutes, 45 minutes, an hour, whatever the case may be. And then after the orgasm, the erection subsides a bit, but you're left with this fullness in the penis. If that fullness is, again, a 4 out of 10, a 3 out of 10, and the penis is bendable, that's not necessarily a priapism risk. But I'm going to assume so in that case, if the doctor's order allows it, you could try increasing your dose. You would want to be very careful about you're using just 15 units. I don't know what happened to you when you injected 10 units, right? So I can't give you any advice about how to change your dose. Are we talking about moving by 1 unit, 2 units, moving by more than that? You would want to look at your dose history and figure out, well, what happened when you injected 10 units? If you injected 10 units, and that was still a 7 out of 10 for 4 hours, or, you know, and then you do 15 and there's no change, all of that is going to inform how you're going to change your dose. Again, it always goes back to the doctor's order, but working specifically with a case manager at menMD or your physician can give you very patient-specific advice on how to answer this question. Let's assume, to answer this as thoroughly as possible, that you're getting a 7 out of 10, and that's what's lasting for 4 hours. And maybe you're having an orgasm and it's not going away. You know, this is territory where I would be concerned. So in that case, I would be more concerned about raising your dose. The types of things that come to mind is, have you ever used a trimix? You talk about you're on bimix. There's a possibility that trying a trimix, and we would go to a lower volume of injection. So bimix 4 is 30/1, that's papaverine phentolamine. You know, have you ever tried a trimix 5, which is 10/31 alprostadil papaverine phentolamine? Bring your dose down. Maybe that third drug, a little bit of alprostadil, there'd be some synergy there between them, and that would cause an increased rigidity without dragging out the erection. So those are the things, again, without having a patient-specific conversation, that come to mind, is maybe trying a trimix to harness the effect of that alprostadil a bit, lowering the dose, or again, looking closely at your dose history and figuring out if it's safe. And then, of course, going back to the very first statement I made, which is how risky is it? What type of erection do you have up to 4 hours? Because if it's a bendable chubby, you're probably a little safer to raise your dose to try for the increased rigidity. Other strategies there, maybe a constriction loop would help. Possibly the use of a VED after the injection. There's many strategies, and so I have hope for you. I do believe that with proper counseling and guidance, you could get to the erection you're looking for in a safe way, but complicated situation, and that you're right on the cusp there. You would want to talk in detail about your situation with somebody.
Very detailed answer. Thank you for that.
Sure. There's a lot there.
Yes, next question here is about VEDs. I was not made aware of the importance of a vacuum pump until 4 years after my prostate cancer diagnosis. During this time, my penis has shrunk. Is it possible to use a VED to regain my length?
It is possible, yeah. So the best course of therapy, if we had a time machine, would be to go back and start using therapy with oral agents, or start using a vacuum device right after surgery, and that would have minimized length loss. But that doesn't mean that you can't regain lost length by starting with a VED now. So I would say yes, there's very clear data that intervention by increasing blood flow into the penis stimulates the muscle tissue, and that there's a good chance that you will regain your length. It may not be that you're going to go back to the full size that your penis was when you were younger prior to surgery, but again, we're talking about smooth muscle in the penis. Any regular stimulation of the penis, sort of like physical therapy. I use this example a lot. If you broke your ankle and were in a cast for a while, your ankle's going to get weak. Those muscles are going to get smaller from immobility. Very similar situation with stimulating the penis. Doesn't happen overnight. You've got to commit to a course of regular use of the VED every morning in the shower, maybe filling it up, filling the penis up with blood, letting it go down, doing that for 5 or 10 minutes, doing it before bed. Doesn't matter when you do it. It's again, just like lifting weights to make your biceps stronger. It's about frequently challenging yourself and doing it over a long period of time. But the data would suggest that regaining some of your lost length is possible, yes, even though you didn't start what I'd call the penile rehab right after surgery and you have lost length. There's still hope for you.
All right, next question here is around scar tissue. Should I be worried about scar tissue developing around the injection site? What should I do to address this or get rid of the scar tissue?
Okay, so you do need to be concerned about scar tissue. This makes me think of the earlier question that I suspected was scar tissue formation for a man who'd been injecting for 20 years. So this is repeated trauma to the penis. So that's part of why we want to rotate injection sites. So rotate injection sites. There's nothing, it's not like there's a cream or something you can put on the penis. This is all just about not overusing the medication and rotating injection sites, rotating in terms of the circumference, rotating in terms of the length, being really vigilant about it, not overusing the medication. And, with that, some people are going to develop scar tissue, some people aren't. Some people get scar tissue who've never even injected, right? There are cases where men will go in for prostate surgery, and simply from the trauma of the surgery and deoxygenation and the nerve disruption that occurs from prostate surgery, men will get an erection in the future and the penis is curved a bit. That's because of some of that smooth muscle tissue has developed fibrosis, has gotten scar tissue, and then much like putting super glue on a sponge, it sort of bends a bit. So it's not necessarily just the injection. So in answering your question, yes, you need to be concerned about scar tissue formation, and you want to be concerned about repeated trauma from the needle and rotating, but it's not all just the needle. The penis can get scar tissue formation simply from lack of stimulation and from other trauma, from surgery. So there is value to getting fresh oxygenated blood into the penis regularly. You could use a VED to do that if you didn't want to inject. You could use a VED on days when you're not injecting. Again, it's about stimulating the penis in the same way you would exercise or stretch your bicep to keep those muscles strong and active. Rotate sites. Don't be overly concerned about scar tissue formation. Again, you have to be aware of it. All you can do is rotate sites and manage it as it comes up. Get a physical exam from your urologist at least annually, so he or she can palpate the penis, feel what's happening, give you advice on areas to avoid. That's my recommendation.
Okay. I have a hard time ejaculating. Why is this happening?
Okay. Excuse me. Could be several reasons for that. I'm going to assume that you're injecting, and after injecting, you're not able to ejaculate. It could be too much rigidity. Guys will sometimes get a 10 out of 10 erection, and it's so rigid that there's issues with the sensation of the penis, nerve compression. That's typically not it, but again, if in the event you're getting this maximally rigid erection, you should back down a little bit from your dose. The other thing that I think happens commonly is, I talked about this early on in the slides when I talked about the normal erection process. The normal process is sexy thoughts, then you stimulate the penis, then you get an erection. Continued stimulation of the penis while having these sexy thoughts is what leads to the orgasm. The orgasm comes from the mind, from the experience, right? Along with sensation on the penis. I had a patient years ago who told me, I remember this so vividly, he had a terrible day at work and a very stressful job, and he came home with the idea that he was gonna, for stress relief, have sex. And he injected, and he's thinking about how frustrated his workday was, and he couldn't have an orgasm. Well, that's because his mind wasn't in the right place. And sometimes I think with the injection, because we've jumped over the sexy thoughts, as I call it, and you inject, and you can inject and go watch Wheel of Fortune, and you're going to get an erection, right? The injections eliminate the need for any type of mental arousal. So my typical answer to begin treating anorgasmia is to make sure that you're properly mentally aroused. If you're doing the injection and you're new, and this is very clinical, you could be hung up on some of that. You could be overly worried about, is my erection gonna last? So my typical first step recommendation is to make sure that you're sufficiently mentally stimulated to get you to a place where your brain is capable of allowing the orgasm. Again, because it's so easy, because you have this automatic erection from the drug, to become disconnected from any type of arousal or stimulation. And if that, try that. If that doesn't work, have a deeper conversation with your case manager or your physician would be the next step.
All right, next question here. Will drinking alcohol reduce the effectiveness of the medication? Should the dose be increased if you've been drinking?
Tricky, right? Tricky question. So yes, broadly, the alcohol is going to reduce your responsiveness to the medication in the same way that most men would say that after they've been drinking, it can be harder to get a natural erection, even when you were younger. So alcohol is a depressant. So yes, any sort of more, and this is the same thing with drugs. I get questions like that all the time. What if I do this drug, that drug? How's that going to work? So it complicates things, right? Now, that said, it's very common to go on a dinner date or something like that and have a glass of wine, have a couple of cocktails, and then come home and want to have sex with your partner. So how do we manage that? Well, first things first, when you're learning, and I talk about 6 injections, you would want to do that and minimize any noise, right? So dial in your dose when you don't have any confounding drug effects, alcohol effects, whatever the case may be. and learn what dose works normally for you. And then assuming it's okay with your doctor, you got to get cleared by your doctor for this. If he says, well, that's okay, you would then sort of see, well, what effect does my normal, I'm going to use 20 units as an example. Let's say 20 units of Trimix number 5 is what's working for you. Well, I go to dinner, I have 2 glasses of wine. My physician said it's okay for me to inject in that situation, but 20 units doesn't work as well. You know, is it reasonable to change your dose a bit? I would say, yeah, most likely. I don't think that we're going to swing all the way up to 40 units. I would imagine we're talking about a very, very small change in your dose, maybe 22 units. Again, always based on the physician's order, but some small increase may help you overcome that effect.
All right, we're at the hour mark here. But we've got a bunch more questions. So if you're up to it, we can ask one or two more questions.
If the crew wants to stick around, I can absolutely give you more time.
Yeah, I think there's some more people hanging on, so we can go through a few more of these, and then we'll wrap up maybe in like 3 to 5 minutes here.
Yeah, let's do it.
Next question here is, when standing, I have an erection, but then when I lie down, my erection goes away. Why, and what can I do?
Yeah, this is another fairly common occurrence. So what you're describing is a venous leak. So you know, if you went to the doctor, maybe they did a Doppler ultrasound on the penis and they would measure arterial inflow, they'd induce an erection, they'd measure venous outflow, and you can do all these tests, and they'll say, well, you have venous leakage, and that's why you have erectile dysfunction. But the sort of quick and dirty at-home test for venous leakage is, I have an erection when I'm standing up. When I lie down, my erection goes away. Surefire sign of venous leakage. So you're doing the injection, that's causing smooth muscle relaxation, that's causing the artery to dilate, and more blood flows into the penis from the artery. When you're standing up, because of your blood pressure, because of certain musculature in your hips and thighs, you know, everything is sort of working as you want it to, and more blood is flowing into the penis. And again, as I said, you know, I sort of use in and out here. The process of getting and maintaining an erection is a delicate balance of blood flow into the penis and venous return out of the penis. So when you're standing, that balance is right, and the right amount is flowing in and the right amount is flowing out. That's producing an erection. When you lie down, that scale tips a bit, the veins open up, and more blood is flowing out, so you lose the erection. Probably if you've injected, what happens is then you say, oh no, I've lost my erection, you stand up, and then the erection comes back because that balance has been reset. So how do you deal with that? Well, you could continue to change your dose and try to dose, again, reasonably based on your doctor's order, increase your dose so that you're able to maintain an erection while you're lying down. That could work. Or it could be that you keep trying that, and the venous leak when you're lying down is so profound that you can't overcome it. So then you'd have to do some more practical strategies, like altering the positions that you're trying to have sex in. You could put your partner towards the edge of the bed, and you stay on your knees, or you stand. You know, what can you do that's going to keep your body in the position that allows you to get a good erection? Alternatively, you could use a constriction loop. So that, you know, that comes with a VED, or they're sold separately. I'm sure that menMD sells them. Stand up, do the injection, get the good erection, tighten the constriction loop around the base of the penis, and that's gonna mechanically trap the blood in the penis so that when you lie down, it can't flow out of the veins. There's a couple of quick tips for you on how to deal with venous leakage and the fact that when you lie down, you're losing your erection. Hope that helps.
All right. Sometimes I have a lump that appears after I inject and it remains for a few days. What's causing this?
So that could be, you know, that could be fluid. Maybe if you're depressing the plunger too quickly, medicine could shear up along the track of the needle into the penis, and it's getting under the skin. So you're outside of the target area, you're outside of the tunica albuginea, let's say, that thicker layer of tissue I talked about earlier, and you're between, if here's the target, and this is the tunica, maybe you're depositing fluid here, or fluid is ending up here under the skin, you're getting a small lump there, your body is having this inflammatory reaction to the medication being under the skin and sending things there to clear that out. So that could be one of the reasons. I would say you want to make sure that you're going, in deep enough with the needle. And again, without the opportunity to really specifically ask about your case, what length of needle you're using, it's hard to give specific advice here, but it could be that you're not going deep enough. A surefire sign of that would be when you depress the plunger. You know, once you get the plunger moving, it should move smoothly, like you're injecting into butter. If that plunger is fighting you the whole time you're injecting, that probably means you're hemmed up in the tunica, not deep enough. So you want to make sure you're injecting deep enough, and then slowly depress the plunger. If sometimes guys, in the interest of getting the needle out of the side of their penis super quickly, will jam down on the plunger really quick, and the target area just can't accommodate that fluid, and again, it can sort of leak out. The other thing that you could do, let's assume you are going deep enough, you're doing everything correctly, make sure to apply pressure to the side of the penis, as I said, like you're squeezing a straw to stop the flow of liquid through a straw. Putting some pressure there for 2 or 3 minutes right after the injection may help minimize some of that leakage back out from the target area under the skin.
All right, last question here. What is the best way to inject when you have essential tremors in the hands? Am I a good candidate for an auto injector?
Yeah, good question. I mentioned a little bit the Insules, which is going to make it easier to see the markings. That's not necessarily your question. Your question was about an auto injector, which I have here. And typically with the tremor, open this up. Typically with the tremor, you know, the more fine movement that you need to make, the harder it is. So the auto injector injectees may make it easier because you are sort of enlarging everything, making it giving you something more substantial to hold on to. We don't have time right now to go through the setup of this. Again, your case manager or your physician can help you. I will say the injector comes with a bunch of tips. This is not as easy as just sort of guessing and throwing it all together. There's some adjustment that needs to happen to make sure that if you look here, you know, you've got to make sure enough of the needle is coming out. You can see that what I called the hub, which is right where the shiny silver needle meets the plastic of the syringe. You can see that I've got this set up so that the hub is coming out a little bit. If you set this up so that not enough of the needle is coming out, very hard to see on my screen there, but you see I've gotten some hit, you know, you're not going to go deep enough. So while yes, an auto injector, absolutely, I would expect to help you because of the tremor, you just want to make sure to take the time to set it up correctly and know that you're still going to have to practice. Okay.
All right. Well, thank you for that. And with that, we are going to go ahead and wrap up the event. Just so everyone knows, the event's going to be available after as an on-demand webinar. We'll have it available on our YouTube channel as well as on our website. So if you missed any of the webinar at all, or if you'd like to go back and relook at the presentation, it's going to be available there at your viewing pleasure. But with that, I'd like to thank Patrick for taking the time to present today. We'd also like to thank everyone listening in for attending this menMD RealTalk webinar. We hope it was informative and you'll join us again in the future. So with that, I'd like to thank everyone again for attending today's webinar. We'll see you at the next one.
Thanks, everybody.